So the first question there, which variable is not fixed in pressure control ventilation? Remember, our tidal volume is not fixed, it's variable. Next question, a 45-year-old man with severe ARDS is ventilated on pressure controlled ventilation. Setting, so we have our pressure controlled above the PEEP as 15 and the PEEP is 10 and respiratory rate is 20. We have our I time as 1 second. Over the next hours, the tidal volume falls from 420 to 280 and the peak pressure is unchanged. What's the most likely cause? So most likely this patient is having what? Likely having worsening lung compliance. So there's worsening lung compliance, which explains why the tidal volume is falling and the peak airway pressure is unchanged. So the best answer there will be B. Moving on to the next question. A ventilated ICU patient on pressure control ventilation has persistent hypercapnia despite adequate tidal volume. Which adjustment best improves the CO2 clearance without increasing the risk of trauma risk? So in this case, you don't want to be going up on the tidal volume. We already have adequate tidal volume. So what else we can do to optimize our CO2, right, is to optimize our ventilation. And remember, we said that minute ventilation equals to what? Equals to respiratory rate multiplied by what? Tidal volume. So we've optimized the tidal volume. We still have a room to go up on the respiratory rate. So the best answer there will be to increase respiratory rates. In pressure control ventilation, increasing PEEP while keeping the inspiratory pressure constant, we do what? Remember, we said that driving pressure equals to what? Driving pressure equals to our inspiratory pressure minus PEEP, right? So that means if I'm increasing PEEP and I'm not changing this, what happens? That will decrease driving pressure. And the driving pressure determines the what? It determines the tidal volume. So that means in that case, the tidal volume is going to decrease. Next question, in a pressure controlled ventilation pressure waveform shows a squared inspiratory plateau, but the flow waveform has reduced peak with prolonged expiration. So there's a decrease in tidal volume. So the tidal volume is decreased, and if you look at the flow waveform, guess what? There's a prolonged expiration. Like we said earlier, in what type of lung pathology do we normally have prolonged expiration? Very good. So that means that patient has what? Increased airway resistance. So there's an obstruction pathology. So this could be an asthma exacerbation or COPD exacerbation or somebody who has a mucus plug, right? Any of those that could cause what? Obstruction to airflow. So the best answer there will be what? Will be increase in airway resistance. Because remember, if this is supposed to be worsening in lung compliance, if this is supposed to be decreasing lung compliance, remember, even the tidal volume will be decreased, but the expiration will be what? Will be shortening. So we're going to have a short expiration. Very good, guys. Moving on to the next question. In pressure control ventilation, the tidal volume drops suddenly and pressure waveform remains unchanged, and expiratory flow shows continuous low level flow throughout the exhalation. So during inspiration, there's no change, but during when you look at the expiration flow waveform, so when you look at the flow waveform and when you look at the expiration phase, that's when there is a decrease. So this tells me that there is no problem with air going into the lungs. It's when there is air is coming out, that's where the air is disappearing to somewhere else instead of coming to the what? To the ventilator. So this tells me that this patient is having what? Air leak. So it to be a great example of air leak. So you can see there the pressure waveform remain the same, but it's the expiratory flow that shows continuous and low level flow throughout the expiration. So that would be a classic example of air leak. And let's go to the last question. In pressure control ventilation, which waveform change indicates improving lung compliance? So if the lung compliance is increasing and you are not changing your inspiratory pressure, guess what? That means if the lung compliance is improving, guess what? Yes, the tidal volume will be what? Increasing. So there has to be increase in tidal volume even at that same what? Pressure, because your lung compliance is improving. Thank you, guys. We've come to the end of today's lecture, guys. Please don't forget to like, subscribe, and share this video with your friends. And I will see you guys in the next lecture. Bye for now.